All right, good afternoon, everyone. Thank you for joining us this afternoon for our research webinar, Use Cases for AI and Health Insurance Claims Data, Screening for Undiagnosed OSA. My name is Rachel Bohr, and I'm the Senior Marketing Director at EnsoData. All right, now I would like to introduce Sam Rusk to you. Sam is co-founder and Chief AI Officer of EnsoData. With more than 10 years of machine learning and signal processing research experience, Sam leads EnsoData's AI team, supporting our FDA-cleared EnsoSleep and core AI research initiatives. His research interests lie in improving the standard of care from diagnosis to therapy, enabling patients to get the best treatment fast. Sam is a charismatic leader focused on democratizing healthcare for all and advancing the confluence of technology and medicine. He is currently a consultant to the AASM's AI Committee, identifying emerging trends in AI technologies in sleep medicine. Sam has a bachelor's degree in electrical engineering from the University of Wisconsin-Madison. And with that, I'll hand over the presentation to Sam.
Awesome. Thank you for the introduction, Rachel. We can dive in. Thanks everyone for coming today. So among the many areas in healthcare that we're interested in today, we look at an abstract from our 2022 Sleep Conference, Evaluation of Healthcare Insurance Claims-Based AI Screening Tools for Undiagnosed OSA. We take a population health-based approach to obstructive sleep apnea, looking at insurance claims and healthcare usage patterns that allow us to screen for undiagnosed sleep apnea patients at large in our populations. So to quickly summarize our agenda for today's presentation, we'll cover why we did the research. We'll take a look at why and what it means more broadly, who we collaborated with, how we did the research, what methods and what data were used, what did we learn, and what were the key takeaways and why does it matter. And then we'll have some time at the end for Q&A with our great research collaborators, so stay tuned for that. All right, so kicking off, why did we do the research? Obstructive sleep apnea affects about 34% of middle-aged men and 17% of women. Researchers estimate that about 80 to 90% of people in the U.S. with OSA are undiagnosed. And OSA is estimated to affect greater than 50 million adults in the US and North America. And so the prevalence of sleep apnea is increasing in our general population in association with the major risk factors, including obesity, aging, diabetes, and others. So OSA exacerbates costs, comorbid conditions, and leads to increased adverse health risks associated with costs over time. So despite the growing awareness and the importance of sleep wellness as a contributor to human health, the accessibility of accurate and affordable OSA diagnostic tools and treatment options are still considered major challenges today. Therefore, we introduce the application of AI screening as an approach that uses insurance claims data as an input to contribute to the efforts of improving screening methodology, helping with early and proper identification of individuals with undiagnosed OSA. So moving on, who did we collaborate with? We had three awesome organizations come together to facilitate this research, the Wisconsin Health Information Organization, the University of Washington, and EnsoData. We have our team live here for Q&A at the end, so write down your questions and you'll be able to ask them, and look forward to some discussion. So moving into the meat and potatoes, how did we do the research? Let's look at the data that we used. The input data was extracted from a dataset composed of medical and pharmacy claims from the years 2016 to 2020 from the Wisconsin All-Payer Claims Database. This included over 4 million patients, 10,000 different ICD codes, and greater than 50 billion in medical spending. For this study specifically, we used the pharmacy and medical claims database, resulting in a total of over 2 million patients and 39,000 unique federal drug identification codes, included within a total of 91 million pharmacy claims in the dataset. In addition, we identified taxonomy of 94 drug groups from the above drugs. Additionally, we look at demographic information, age and gender, to account for their contributions to OSA classification. The retrieved data was used to construct input features by calculating drug frequencies per subject. We define drug frequency features by counting the total number of claims for each unique drug or drug group for each subject, resulting in a feature vector of 39,000 drug frequencies in 94 different drug groups. And so more simply, drug frequency features are the number of medications an individual has been prescribed cumulatively. Looking at the target, what did we want to predict in this research? we wanted to distinguish between positive OSA and negative OSA patients. We define these as follows. A positive OSA patient was defined as an individual who had a medical claim for a sleep test CPT code, so any of the 958 codes, and a medical claim with the ICD-10 code for OSA. Negative patients were defined by the opposite, or the absence of both of those. So this group had neither a sleep test procedure CPT code or an ICD-10 OSA code. Looking at the models that we used, two models were analyzed in the performance of distinguishing between positive and negative OSA patients, Logistic Regression and XGBoost. Each model performance was evaluated by the receiver operating curve, area under the curve, the ROC-AUC, and that was through a 10-fold cross-validation methodology. Additionally, we performed model explainability analysis through SHAP, both global and local, which resulted in the identification of the top features that contributed to the classification of OSA. And we can show the results of those later on. Here's a visual representation to help understand how we did this analysis. This is the workflow and a visual representation of how the data flows through our analysis pipeline. You can see the pharmacy claims database going into the medication frequency features, where they were calculated for both individual and the drug group counts. On the bottom row, we calculate the target. The medical claims database went into the feature construction where positive OSA were defined by the sleep test CPT and the ICD-10 code, and the opposite for the negative OSA patients. Those features were calculated for each of the over 2 million patients. And then on the far right, you can see our modeling where both the targets and the drug frequency features were fed into the logistic regression and the XGBoost model. They were both evaluated for ROC-AUC. And before we dive into the results, I wanted to expand a bit on some of the basic terms that I've spoken about and that were used in our machine learning analysis. And so first, a logistic regression model is a linear machine learning model that finds a linear combination of the input features to optimize performance for the target. And so this is, we often use this as a baseline in our analysis. An XGBoost model, on the other hand, is a tree-based model that uses a tree structure to predict the target. And so it can find different kinds of relationships between the input features. The ROC-AUC is the area under the receiver operating curve. This measures the balance between precision and recall for model performance as you sweep over the thresholds of prediction. And so it's a good measure of overall model performance, and that's why we use it to evaluate and compare. And then finally, SHAP analysis is a technique to understand the way that individual features contribute to the prediction and how strong they'll impact the output. It can represent quantitatively the relevance to the target that you're trying to predict. And so through these different methodologies, we employed to help build and measure the different machine learning models' performance. So now into the results, the exciting part. Overall, in summary, logistic regression and XGBoost models show that the models use both age and gender with individual medications have the best performance. So we see both age and gender helping the prediction of OSA. In addition, we show that our results show that the XGBoost models perform better compared to the logistic regression models when individual medications are used. And then lastly, our findings indicate that the performance of the XGBoost model is improved considerably as both one or both of the demographic features are included. So looking at these in more detail, you can see the curves on the left. They're a little bit, it's a little bit small to interpret, but you can see the different model performance. On the top row, you have the XGBoost models, and then in the bottom row, you have the logistic regression models. In the right table, those curves are translated into numbers. And so you can see as we add age and gender to the drugs and the drug groups, you see increased ROC-AUC for performance. And then also you can see the different relationships between how the drug group and the drugs interacted with the XGBoost and the linear regression models. And so the XGBoost actually struggles to use the drug groups as accurately as the individual drugs. And so there's some deeper understanding of how these models interact with these specific features, but some very interesting analysis here. Basically, overall showing some trends that we can deduce. And so going a step further to understand why the models, how they were able to distinguish between positive and negative OSA, we leveraged the SHAP analysis, both for linear explainer and tree explainer for the logistic regression and the XGBoost models respectively. The analysis using individual medications and drug groups indicate that at a global level, medications used for or medications treating diabetes, hypertension, and hyperlipidemia medications are among the top features that pulled classifiers toward OSA positive. And so here is an overview of those individual medications and the values that had the highest SHAP values for individual medications. And then here we see the same for the drug groups. So positive SHAP values are positive SHAP values move the targets or the specific examples closer to OSA prediction, and then the negative values are the opposite, where they would be pulling towards normal or no OSA. And so kind of finalizing, why does it matter? Why did we do this? And maybe what does it mean? In this research study, we demonstrate that health insurance claims records contain predictive information that can aid in a more systematic screening of undiagnosed conditions like OSA. And furthermore, in a statistical analysis of feature importance, we observed that medications indicative and that we know are comorbid with OSA help in predicting to distinguish between OSA and normal. In addition, we identified that demographic features, age and gender, are among the top features in combination with our other medication frequencies that contribute to an improved AI screening methodology. And so current tools like StopBank contain important information. We should use those in combination with other data sources to help better distinguish between OSA and negative OSA. And then additionally, the presented AI research shows promise for screening not just OSA, but other undiagnosed diseases. I think we can expect approaches like this to support patients regarding other diagnostic procedures and predictions in ongoing efforts of continuing to develop personalized healthcare approaches. And finally, some closing thoughts. At a high-level perspective, there are existing patterns in healthcare claims data to help screen for potentially many diseases. We should look at the data that's already flowing through our ecosystem to help improve the standard of care. Machine learning and statistical tools will be critical to support clinicians to diagnose and treat earlier, manage growing populations. 39,000 medication types is more than most of us can put in our head at one time. And so implementing AI screening solutions will help health systems and hospitals around the country and the world manage patients with multiple chronic comorbid conditions that often exacerbate health costs. And so we should use these tools as soon as we can. And so that is an overview of the research. Thanks all for listening. We are going to conclude and move on to our Q&A session with our awesome collaborators. I can turn it over to Chris, who will introduce them and then launch us into a fruitful discussion.
Thank you very much, Sam, for the excellent talk. And so I'll go ahead and share some introductions for our panelists. To our panelists, we can go ahead and return our videos on. And so to kick those off, and Sam and I already know EnsoData's Chief AI Officer and Chief Research Officer, respectively. So I'll go right into the intros for our amazing research collaborators and panelists. Panelist number one is Dana Richardson, who is the Chief Executive Officer for the Wisconsin Health Information Organization, HOYO, Wisconsin's all-payer claims database. HOYO provides data and information about Wisconsin's healthcare delivery system to state government, health plans, employers, provider organizations, and others to support the improvement of quality, safety, and cost efficiency in care for Wisconsinites. Dana also serves on the board of directors for Wisconsin Statewide Health Information Exchange and Leadership Lessons Forum. Prior to joining HOYO, Dana was the director of PCP operations for the American Medical Association, that's the AMA, where she staffed the PCPI board of directors and led the development of the National Quality Registry Network. Prior to that, she served as vice president of quality initiatives for the Wisconsin Hospital Association and began her career in positions in clinical roles as an intensive care nurse for several years. Panelist number two is Dr. Tim Bartholow. Dr. Bartholow fosters collaborations between providers, payers, communities seeking to tangibly improve healthcare coordination and affordability. Dr. Bartholow serves in a variety of leadership roles with healthcare quality organizations that include Wisconsin CMS contracted Quality Innovation Network, Wisconsin Statewide Health Information Network, Wisconsin Health Information Organization, and serves on the committee for Masters of Public Health Programs as an advisor to the Population Health Institute for UW-Madison. Dr. Bartholow previously served as the Chief Medical Officer for WEA Trust and also has served on the board of directors for the Wisconsin Collaborative for Healthcare Quality and the United Way of Dane County. Lastly, but certainly not least, we have panelist number 3, and that's Dr. Nate Watson. Nate, in addition to being our Chief Medical Officer, currently is a professor for Vice Chair of Faculty Affairs in the Department of Neurology, co-director of the Sleep Center, and director of the Harborview Medical Center Sleep Clinic at the University of Washington. Nate is a fellow of the American Academy of Sleep Medicine and a former president of the American Academy of Sleep Medicine as well. So with that, I'll hand it back to our MC for the webinar, Rachel, to kick things off with our first Q&A question for the panel.
All right, thank you, Chris. Great introductions. All right, I'm going to start with the first question here. I'm curious if the input data can be affected by the inception of the COVID pandemic in 2020. Did you consider 2016 through 2019 to see if 2020 would show a spike in claims, or perhaps a decline due to the postponement of care in many institutions due to the pandemic? And I'm not sure who would like to take that. So Chris, I will let you assign that question.
I could give a specific answer, and perhaps we could open it up to the panel for some additional comments. I think that, this, initial work, I think, didn't include kind of COVID specific statistical analysis within its scope. I think initially we wanted to approach this as a feasibility study, demonstrate the feasibility of AI applications, predictive modeling applied to claims data, the kinds of information that could be extracted from that, and to start to look at, the relationships between, drugs, medications, therapies, and possible undiagnosed conditions, in a bigger way. I think that that's an important variable for future work. COVID certainly had an impact on, access to care and the continuity of that. And so, I can comment that in one follow-up project that we're doing, in a related data set, that's a CMS claims data set, we are kind of doing some COVID-specific endpoints to look at, changes in patterns in access that were different as a result of the impact that COVID had on our system. So that's something we're excited to follow up about too.
So I can probably add to that because we have looked at access to care as far as the volume of claims that came in, really going back to 2017 all the way through 2022. And what we saw in March of 2020 was a significant drop in claim volume, which means people weren't receiving care, right? No big surprise. But it actually came back relatively quickly. Within probably 6 months or so, the vast majority of care was being provided, sometimes through different means. So there was a bit of an uptake in telehealth and other things as opposed to an in-clinic visit. However, I would say it wasn't equal across all streams of care. So cancer care, for example, we didn't see a dip at all. So that's good news, right? People that had cancer were still receiving care. We didn't see a dip in things like chronic kidney disease. It was more the surgical procedures that could be deferred, as well as some well type of visits on the outpatient side. But again, most care actually came back really within 6 months. So for the purpose of this study, it probably didn't really have an impact.
I'm going to add, I expect that through time, we're going to see many impacts that were experienced through COVID. To Dana's point, preventative care or wellness care, I think, had substantial reductions, and I'm not sure that all of that's returned to normal just yet. Colorectal cancer screening and such took a pretty tough hit early on. We did see immunizations actually for children come back fairly quickly, generally through clinical registries, and we're heartened to see that. I am concerned that we're going to see some delayed care through time. The study here doesn't necessarily address all of those questions, but these kinds of technologies are going to be part of what defines how much delay and how severe the illnesses are that might have been altered had we been able to be more attentive during a period of COVID.
You know, as we think about the other factors that may influence this analysis, you know, COVID is one. The other fact of the matter is, and Sam alluded to this, is that the vast majority of people with sleep apnea are undiagnosed and untreated right now. And so clearly many people in the designated group of not having sleep apnea basically probably will have it, but it's undiagnosed. And I think we need to acknowledge that reality probably biases the study towards the null, which to me makes the results even more impressive.
All right, thank you, everyone. Next question, can you clarify and or describe the differences in utilizing EHR data versus claims data for AI ML model development? And then follow up on that, is any benefits or drawbacks? Sounds like a Chris or a Sam question.
Yeah, perhaps Sam, you could comment on this one as well. I think, you know, at a high level, you know, one can think about, you know, a layer of data standardization that is kind of higher level than, you know, either of those two data sources. Ultimately, for diagnoses, those can be things like ICD codes, ICD-9, ICD-10 for medications. In this scenario, we utilized a federal medication drug ID codes to be able to standardize those. And so independent of the input source, you know, we can come up with a common structure that allows that data to be treated, you know, fairly similarly from an AI modeling standpoint. So ultimately, you know, even though the primary data source was healthcare insurance claims records, we were able to extract clinical information from those, like diagnoses and like, you know, the depth and breadth of medication usage, from which we could, you know, then generate predictive models with the performance that we saw today. One benefit of claims data as well is that it includes financial information. So in this, you know, database, we were able to look at, you know, more than $50 billion in paid medical expenditures, and having those types of data points as well allows for analyses not only of clinical opportunities and care gaps, but also to help to quantify, you know, the potential financial benefit, you know, to governments and payer organizations that would be achievable through closing those care gaps as well.
I'm gonna jump in and just add that both of the databases, whether it's a EHR database or an aggregate of EHR data and an aggregate of claims data, bring different answers, right? And the one that I think that, you know, those of us that are clinicians, we will notice or know that we will send patients out of a facility with an EHR recorded medication, and something like 30%, and maybe it's a little bit higher or lower, but around 30% of the time, because of barriers, the patient isn't able actually to pick up that prescription. And unless you had a claims database, you wouldn't know that, right? You don't have necessarily a confirmed fill that comes out of an EHR. And it's been humbling to watch this, right? Not only that, in the claims database, we can actually see what the adherence, the overall adherence rate is, which is also not 100%, right? So somebody gets treated for hypertension, and ultimately they're taking 40% or 70% of their medications. That's an important conversation to have with the patient, and the data that is analyzed by Enso is able to help understand, are patients actually benefiting from the therapies that we're trying to apply to help their sleep apnea.
Well, and I think to me that brings up another question when we talk about additional pathways or future work that can be done. Because, you know, we know when we treat sleep apnea that hypertension gets a little bit better, and in some people it can impact the number of drugs that are prescribed or that they take for the disorder. And what I'd like to better understand is what impact does the diagnosis and treatment of sleep apnea have on other medications being filled, particularly in the realm of diabetes, that we know has a tight relationship with OSA. So I think, this is just the beginning of the different ways that we can explore the importance of diagnosing and treating sleep apnea. And, we need to continue to make the economic argument to all the stakeholders here, because there's a tremendous opportunity to recoup healthcare dollars if we address the massive undiagnosed and untreated burden of sleep apnea that's out there. Frost and Sullivan did a report about 5 years ago, which indicated the cost to the U.S. economy is about $100 billion annually for untreated and undiagnosed obstructive sleep apnea. Much of that is related to workplace absenteeism and presenteeism, but certainly healthcare utilization and motor vehicle accident risk are big factors as well. So the numbers are big, the opportunity is big for payers to recoup some of these costs if we can get them to focus on the importance of the diagnosis and treatment of sleep apnea.
Yeah, I think that's a great segue into just in general, what are your biggest takeaways, from this research? And I'd love for the rest of the panelists to kind of provide that perspective as well.
Dana, you're up. But you have to come
Dana,
off
I think
mute.
you're on mute. Yeah, you're on mute doing that.
Sorry. I think what these kind of studies do is they validate things that we kind of clinically maybe suspect or we even know, right? So it's, we knew that there was some kind of correlation between diabetes and sleep apnea. We knew that there was a correlation between age and sleep apnea. But what AI can do, in my opinion, that is very difficult to do in other types of research is that it can take multiple factors at one time, and it can begin to actually weight the relative influence that each of them have. I'm not a statistician, so I'm trying to get this right. But by doing that, it helps us to kind of flush out what's really important, right? And so how do you take that information then in this situation where we learned that diabetes and hypertension and hypercholesterolemia are really important components to sleep apnea? How can we now turn that and say, will this help us to identify people on the ground in real life who are at higher risk? So I see this as an opportunity to use these more advanced research tools to really be able to narrow our focus on who are the people that we should be spending more time and attention to screen and see if they have sleep apnea. Because the reality is mass screening is very expensive, first of all, but it's also, it just doesn't happen, right? So how can we take these learnings and turn them into something that creates real life value to patients moving forward?
Dr. Watson, you should jump in.
Yeah, I would say, look, we're faced with the reality that primary care is, they're already working very hard and they have very little time to investigate whether or not sleep disorders are present if the patient doesn't bring it to them as their primary complaint. And we layer that on top of the harsh reality that there's little to no sleep medicine education going on in medical schools, internships, or residencies, and fellowships. And so we have to find a way to make it as easy as possible for primary care doctors to identify patients that need to be referred forward in order to get their sleep apnea diagnosed and treated. And then as we continue to do this work, we have to take it a step further. We have to consider what's the value proposition to a primary care doctor who's overworked and they already have more than they can handle to address this problem. And you know, if we can show them and we can prove to them that, hey, if you spend time on this, your patient panel will become healthier. They'll have fewer problems with cardiovascular diseases, metabolic diseases, mental health related problems. You know, when they show up to you for their annual visit, they're just going to be less sick in general, and they're going to be ostensibly easier to manage. So I think we have to continue to build this, because really, until we get primary care focused on this and to partner with us as a sleep medicine community to solve these big problems, we're not going to get where we want to go.
And then I'm going to jump in with two reactions to big takeaways. One is, as a chief medical officer for a not-for-profit insurance company recently, we knew that we had people with multiple morbidity, right? They had diabetes, and they had hypertension, and they had several other risk factors for sleep apnea. And we knew that the people who were actually already diagnosed with sleep apnea weren't actually always adherent with their recommended therapy. But more concerningly, perhaps, we also knew that we had large groups of people that were not diagnosed. And so instead of approaching every patient in a risk pool, right? If we have 100,000 people insured, you could send them a survey, I suppose, right? And say, have you had any of these symptoms? But the smarter, more targeted way to approach this question is, look, do you have these comorbidities, or do you have a signature of some kind, either in EHR data or in claims data, that indicate that it's very likely that you have a difficulty? And what happens there is we can target those patients, right? We can actually send messages that are hopefully supportive, that are asking if the patient would like to be evaluated, or do you think that you have any of these symptoms, and is there a way that we can be assistive? So in the role of a chief medical officer, I think this is a grand opportunity, not just for sleep apnea, but for 30 illnesses, right? On the clinical side, as a family doc, I know that in the past we relied on the brilliance of the human mind to make every observation possible in the day, a paper chart, now an electronic medical record, but you can't have the kind of awareness that the AI here has presented. And I think that we're talking about AI and medical care as a novel finding. I think in the future, it's going to be a part of diligence. And we're not any longer going to say, it was okay to have missed the probability that somebody had an illness. So I celebrate that this kind of technology could focus my time to the things that are most important in trying to care for a patient.
That's great. Chris and Sam, do you have anything to add on your biggest takeaways from the research?
Sam, what do you think?
I mean, my takeaways are similar to the panel here. There is existing patterns. I made this point during the slides, but there are existing patterns that we're not leveraging today, and we're relying on more manual or nothing at all in some cases. And so at the very least, it's compelling to try to use what's already flowing through the system to our advantage and to help patients. And then from there, ChatGPT 4 exists and is launched now. The potential for what this can do in the future it will be massive.
Mm-hmm. Yeah, and I would add too, I think that it's a glimpse at the potential of going further in this direction. We look at the initial results, the findings. I think the feature importances are not super surprising, right? We see cardiac disease, we see diabetes, and there are well-established associations, between metabolic disorders, cardiovascular disorders, and sleep apnea. As it stands today, we think about disease, we think about both, chronic and acute physiologic adaptation. What does that mean? Short term, and long-term changes in physiology that are the result of disease. As it relates to cardiac disease and sleep apnea, I don't know if we understand well enough to say what's causing what causally and what direction, but statistically in a population, when you look at patients with these diagnoses and multiple morbidities, statistically you see a higher incidence of sleep apnea related to the prevalence of sleep apnea being so high in those comorbidities. So what's really, I think, insightful about this is not just that, right? We could utilize the diagnoses themselves, the ICD codes, but in studying the relationships based on the therapies, we're actually looking at something that may represent even higher resolution information. Why is that? Well, there are multiple therapies typically associated with each diagnosis. For sleep apnea, as an example, positive airway pressure therapies, neuromodulation therapies, oral appliance therapies, surgeries, and/or different pharmacological therapies. And within each of those categories, multiple options, right? And so in a way, we're getting a more specific insight, not only into a diagnosis, but into kind of patterns of access and utilization on a particular therapy, over time, and how that all ties together. That still is just a slice, however, of the overall data. There are the diagnostic codes themselves, and there's a lot more in the way of information in the database. So, in its depth, it's more than 2 terabytes, 2,000 gigabytes, and its breadth, there's a lot more that we could put into it. And so this really represents just the starting point, for what's possible and going further in this direction, what we can learn along the way, and how this can translate into practical tools that could be used to close care gaps, with this temporal data that exists.
Yeah, I think, as we get more sophisticated, the idea is to swim further upstream. Chris's comment about physiological adaptation makes me think that, there's a moment in someone's journey to diabetes where they go, from pre-diabetes to having diabetes, and where it may be difficult to turn the clock back. But perhaps there are opportunities to identify people early enough on in the generation of their disease process to bend the curve of the incidence of the disease ultimately. And that's what we really want to be able to research and do in order to realize the vision of the healthier primary care panel in the long term, to prevent some of these entrenched disease physiologic pathways from taking over as a one-way street that you can't go back from.
Dana, I'm going to riff off that. Do you want to make any comment first?
Well, I was simply going to say that's one of the conversations we've had recently with EnsoData, and that is to see if there is an opportunity to use their skills and knowledge and the WEO data in order to identify people with pre-diabetes, right? Because that before the diagnosis, Dr. Watson, I think is exactly what we're thinking about. Is there an opportunity to intervene early before people are diagnosed? And maybe in the end, we can't prevent it altogether, but perhaps we can push it back, right? If you could push the onset of type 2 diabetes back even 10 years, for example, people would live a much higher quality of life much longer and maybe not end up with such severe disease towards the end, right? So that is actually an opportunity that we've been talking about, and there is some grant funding that's been applied for, so we're hopeful that we have the chance to work on that.
Yeah, and there are obviously, I mean, there are lots of diagnoses that this could apply to, right? Are people, with blood pressure adequately identified, or are people with lung disease adequately identified, and so forth. Diabetes is interesting because fully a third, if not in some states a half, of the population are actually known to be in a pre-diabetic state, a good number of those individuals are going to go on to have what is at least partially avoidable, or at least we're able to delay. And to Dana's point, if you delay, if it's 5 years, 15 or longer years, the issue around, for instance, prediabetes to diabetes may not be as much an issue in the person's lifetime. So we think that we'll be able to identify individuals who may be more likely to convert sooner. And it's the same sort of a problem that any risk pool has around, do you approach an entire population of potential folks who could be affected, or can you target the individuals with messages that are inviting, that are respectful, and raise the question, should we do some further evaluation of your circumstances and see if we can, improve your health over this next decade. The primary caregivers too, again, we've said this already around sleep, but the primary caregivers are eager to have an understanding of who is at most risk. Some of this will seem somewhat obvious, but I have to admit, being a long-term primary caregiver, that there are too many times when I thought I knew the patient and we discovered that I had missed either their elevated blood pressure or a combination of drugs that actually caused an adverse drug event and such. And I no human brain, right, is sufficient to be able to screen for everything possible to help a patient. And there's a significant body of literature now around how human intelligence and artificial intelligence together actually can give you a better result. Obviously done carefully, right? But it can give you a better result.
Thank you for all of that. That's fantastic. A couple additional questions, and we may have covered some of these in when you all were sharing your thoughts. Do you think AI can assist with predicting patient compliance with treatment?
Well, insofar as, I'm going to take the first shot, insofar as we know, and Dana, you should talk a little bit about the social determinants of health capability that WEO has. We know that there are known barriers, right? And we can describe those barriers in several different ways. And so, yes, I think there are plenty of ways to ask the question, who may benefit. There's also, I think, some additional work being done in diagnostics around, who actually is going to benefit from a biologic medication, by their biologic fingerprint. But maybe the social determinant analysis, Dana, what do we know about that?
Yeah, so one of the things that we did a couple of years ago is we were able to take each of the individuals in our database and apply to them not on a one-to-one basis. It is at a small geographic level at the census block, but we were able to apply different social and economic factors to the individuals, as well as things like an area deprivation index. And so our hope is that by adding in that information, we can expand the way we think about things like compliance. I'm not a big fan of the word compliance because, as Tim mentioned, there's a lot of barriers. A lot of people want to be compliant. It's just not as easy as it seems. But are there specific subpopulations that are far more challenged? Again, we know these things kind of intuitively, right? If you can't afford your medications, you're probably not going to buy them and take them. But how do we actually identify these people, right, in the system? So while all of the data that we provide is de-identified data, so for example, what EnsoData used was de-identified, we actually do have all the identificating information on those people. So can we take knowledge like is being created here and then turn it around and deliver information back, both to communities perhaps, people that are interested in the community and helping people to access things that they have difficulty doing, or to providers. I mean, I see things like compliance with medication as more of a social issue than it is an individual patient issue, and something that more than providers need to work on.
I think as I understand it, the preferred term is adherence as opposed to compliance. And certainly it's a great question. And this is an area of interest and focus for EnsoData, because, we know it's a huge missed opportunity. If you get a patient all the way through the diagnostic process, which is, as we mentioned earlier, Sam mentioned, 80–90% of people never even get to that point. And then we know maybe roughly 30% of those individuals are not adherent to their therapy. You've gotten yourself to the precipice of success with the patient, and then you kind of steal failure from the jaws, or defeat from the jaws of victory, I would say. And so, we have done work looking at aspects of the various types of prescriptions and demographic characteristics and other personal characteristics to help identify patients at higher risk for treatment non-adherence. And so EnsoData is working on helping sleep labs identify who these people are going to be up front, so that we can focus our resources on the high value targets of the individuals that we kind of know are going to struggle or have some problems. So whether that's a motivational interviewing program, whether that's acclimatization to PAP therapy with the help of a psychologist, whatever programs we put together to improve treatment adherence, we'll be able to focus it on the people that would benefit from it most.
Mm-hmm. That's a great point, Nate. And I think one last thing that I would add there as well is one thing that I'm excited about is there's two different threads of research that we can kind of pull together here. Looking at claims data or EHR data alone, we've done some initial work in looking at how prior patterns of access or utilization might translate to the degree of future adherence or compliance. As an example, if I've missed 12 appointments in the last 2 years, how likely am I to miss a 13th? Sort of a thing. Separately, we've looked at more than 90 million nights of therapy data, remote monitoring and patient monitoring data from several 100,000 people, and the ability to bring these two threads together represents a big opportunity to increase the predictive power and capability. At the onset, I wouldn't characterize it as necessarily the risk that people are going to be uncompliant, but maybe more so as a way to think about triaging clinical resources around education and making that upfront investment for better short and long-term success and retention on those therapies. I think that there's a lot of ways that I think that these tools could be utilized to help to inform that.
Chris, one thing we haven't said much or anything about is our opportunity to actually talk also about the affordability of care. And I'm going to echo my colleagues, sensitivity to compliance versus adherence. Many of us were taught that, to assess the patient's health literacy. And I think part of what we're trying to do is we're trying to be more health literate for the patient, right? As clinicians, the burden is on the clinician to have a better understanding. one of the places that is key is, many patients are priced out of their ability to participate, whether they can't quite buy their, their medication, or they can't pay the gas to, get to the appointment. They can't take time off of work and jeopardize benefits. There are a variety of trade-offs that I don't think, we as clinicians are always or can be always aware of. We can know from these analyses, ultimately, what is the sort of resource optimized way to approach a problem. How, you'll see in various components Dr. Watson's day, he has an opportunity to pick expensive things or things that are more affordable for the patient. And that's true across a whole variety of the practice of care is a minute by minute opportunity to be more aware of how we're using the patient's resources. If the patient goes to work and they get benefits at work, what we know is they have earned salary and they have earned healthcare benefit. And when we spend more than we would need to get to the highest quality care, right? If the goal is highest quality care, when we spend more than we needed to, it's coming out of their pocket somehow.
Yeah, and I would add to that, Tim, healthcare costs are rising everywhere, right? All across the US. We know that our outcomes are not as good as other countries for the amount of money we spend. And at the same time, we have really exciting and interesting new treatment opportunities coming onto the market now, both medication therapies as well as other types of non-invasive ways to treat. But these things are going to come with big price tags, right? And we want to be able to offer those kinds of solutions and ways to help people both live longer, but also just feel better and have a higher quality of life while they're living. But how are we going to afford it all? And so one of the things that I've always thought AI really has the opportunity to do that's been very elusive in other kind of standard research studies is comparative effectiveness. Can we figure out which patients can, use less expensive treatments and still end up with a good output, right? Outcome, and which patients we really need to spend these additional dollars on, because right now we don't have those answers. And so, it becomes kind of a fight between the payer and the provider as to how much can we spend and on whom and for what, right? So any opportunity in that space, I think, would be welcome by all.
Yeah, I think, AI holds the promise of cluster analysis to identify specific phenotypes of sleep disorders that will respond to specific treatments. And if we're able to do that, then we're going to get people on the right treatment faster. That saves time and money. So I think, in the future, those are great points, Dana, and I think there's a huge opportunity there to improve healthcare and reduce healthcare cost through AI.
And Nate, sometimes those treatments, right, are going to be more expensive, right? I mean, there are going to be times where the best treatment is something that's more expensive quickly, right? Then there are other times where we've said, well, we have something new and it's way more expensive, and we've never proven that it's better than the other thing, and it sometimes is not as good as the existing therapy. Let alone have we proven the safety, right, of new agents. So,
and I think that the last thing I would add, those are excellent comments. Tim, to your question about affordability, I think that root challenge of affordability and cost of care is part of what gets at the practicality, I think, of these methods in this direction. We're looking for practical, scalable, effective, accurate screening tools. Most of the data we look at in healthcare is a snapshot in time, but not only that, we don't have genomics on everybody. We don't have MRIs on everybody. Those things are very expensive, and those are still a snapshot in time. Wearables are an exciting trend as they're introducing more continuous and longitudinal data to the fold, but still people don't all have wearables yet. And the cool thing about the application of AI, predictive AI to EHR data and claims data is it's already there. So, to the extent we're motivated, as a community to go out there and close care gaps, this is one way that, we have the ability and have the early indication that the tools will work to go out there and start solving those problems.
Chris, it seems prudent, right? It seems prudent in, that yes, we would want additional information if it's really helpful, right? But we should be using the stuff we have, right? And we are not, I give us a C minus D plus on using, the data we have. I'm just grateful for what you all as a team have shown can be done.
Yeah.
Excellent. Does anyone have any final thoughts? I know we're at the top of the hour, so I want to respect your time, but this has just been some fantastic insight that I'm sure all of our attendees have thoroughly appreciated. Anything else?
Thanks to the Enso team for taking this on, you guys. Appreciate it very much.
Well, thank you. Thanks for everything, for collaborating, for being on this webinar today, taking your time. So thank you so much for your participation and for our attendees for being on.